So I'll just quickly go through, just briefly, on the evidence that has brought us long-acting ART, touch a little bit about considerations for guidelines as countries move to widespread use of long-acting ART, and touch on some issues we need to do in the future. So let's see. All right. So what you see there is the two products or that make up the long-acting ART that is currently on the market. It's cabotegravir, which is an integrase strand transferase inhibitor, as well as rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor. They're indicated in the treatment of HIV infection in adults who are virologically suppressed, i.e. less than 50 copies, and have no known suspected resistance to either rilpivirine or cabotegravir. So they are dosed intramuscularly by the healthcare provider, and prior to injections, there's an optional oral lead-in prior to the injections being administered either every 4 weeks or every 8 weeks. Rilpivirine requires special storage at 2 to 8 degrees, and with cabotegravir, there's no special storage conditions. So this map is just showing it's a snapshot that was done earlier this year, just showing registrations globally. You'll see that it's picking up steam right across on every continent, right throughout the world. And here in sub-Saharan Africa, we started with South Africa and Botswana, but I'm pretty sure other countries are now either approved or are considering approval of long-acting cabotegravir and rilpivirine. So I'm just going to quickly, this slide might be a little difficult to see from the back, but I'm just going to quickly summarize the phase 2 and 3 clinical trials, starting with LATE and LATE 2. These were phase 2B trials, and LATE was randomized, partly masked, multi-center, so dose-ranging trial that really has just established that the 30 milligrams cabotegravir was the optimal dose, oral dose. In LATE 2, these were naive patients who, after 20 weeks on oral cabotegravir, bacavir, and emtricitabine, with viral loads of less than 50, were randomized 2:2:1 to long-acting cabotegravir rilpivirine every 4 weeks, also every 8 weeks, and then continued oral therapy. So we know that at 96 weeks, this trial also showed non-inferiority of the injectables versus the oral formulations. The same thing with the FLAIR trial. This one was a phase 3 trial, and this were treatment-naive patients who had 20 weeks of daily oral medications, bacavir, 3TC, and DTG, who had viral loads less than 50, were assigned 1:1 to continue either oral treatment or switch to monthly injectable cabotegravir. Again, we see that at 48 weeks here, at 2.1% of participants who received the long-acting injectables versus 2.5% of those who continued on oral therapy did not achieve the endpoint of less than 50, or viral loads of less than 50. Again, showing the non-inferiority of the injectable formulations versus oral. Of note in the FLAIR trial was that there was increased treatment satisfaction in 91% of participants who were taking the injectables. In the ATLAS and ATLAS 2M trials, again, these were phase 3 trials, and And in Atlas, it was treatment-experienced patients this time, with, again, recruited with viral loads less than 50 for at least 6 months on the oral treatment, and then randomly assigned 1-to-1 for continued oral treatment or switched to monthly long-acting cabotegravir rilpivirine. But in 2M, again, it was a treatment-experienced patients, but this time the comparison was between long-acting injections given every 8 weeks versus every 4 weeks. And again, these two trials also demonstrated that the long-acting cabotegravir rilpivirine was non-inferior to the oral treatment, but also that the long-acting cabotegravir rilpivirine given every 8 weeks was also non-inferior to that given every 4 weeks. And again, in these trials, there was greater patient satisfaction reported with the long-acting cabotegravir rilpivirine. So these have been sort of the main clinical requirements, which I briefly touched on in an earlier slide. So basically, adult patients that have to be 18 years or older, virologically suppressed, and no known or suspected resistance to either cabotegravir or rilpivirine, and no contraindications no contraindications or drug or potential drug interactions suspected. So this is the next 2 slides will just be going through some considerations for developing guidelines, especially now as the use of the injectables is picking up pace across the continent. I know in Botswana we've had to go through this just recently. So we have to look at the patients for whom cabotegravir and rilpivirine is not recommended, right? So patients with active hepatitis B infection, those with previous treatment with iron STIs and NNRTIs, those known or suspected to have resistance mutations to the 2 classes of drugs, and then what to do in pregnancy and breastfeeding or in children. We also have to consider administration. So who should be required? What licensing and training should be required for those administering long-acting ART, and then also preparation and administration for the local setting beyond what is provided for by the manufacturer. And then in terms of the dosing strategy, we really should give guidance on the use of oral lead-in. Is it going to be optional or not, and so on, and then loading and maintenance with either every 4 weeks or every 8 weeks dosing. Managing missed injections is an important one, so that giving guidance on how to use oral medications to cover gaps in injections, and then also managing how to resume injections once they've had to be interrupted. And then discontinuing injectables altogether in cases where you've got confirmed virologic failure or evidence of INSTI and NNRTI resistance, and then also extended or in cases where you've got extended or frequent gaps occurring between injections, and then initiating, and then also how to then manage initiating fully suppressive oral therapy. And then laboratory testing is another consideration. So what we do at baseline, what we do for routine monitoring in accordance to what is appropriate for the local setting. And then just on this last slide, just to touch on some ongoing and future considerations, we know that specific populations were not included in these foundational clinical trials, so that we still need more information or more data on how to handle those with concomitant hepatitis B infections, and then also what to do with pregnancy and breastfeeding, and then also what to do, how to handle those with a history of virologic failure who are in STI and NNRTI resistance-associated mutations. There is already some work, some studies that are coming out on this, and then those with gluteal implants, and just the need to evaluate alternative sites for the IM, for the intramuscular injections. So the era of long-acting ART is really just beginning with long-acting cabotegravir and rilpivirine, and it, the evidence for its potential to transform treatment in a patient-centered way is compelling. So we can expect to see more robust ARVs with high genetic barriers to resistance, longer dosing intervals, and potentially implantable options. Thank you.